Good morning, everybody, and welcome to the Stage 3 Meaningful Use Final Rule webinar. Just a heads up, we will be recording this session. Once we complete all of our Stage 3 webinars, we'll be posting the best session up on the CliniSync YouTube channel. Another thing we do on the YouTube channel is since we're recording every session, we do capture the Q&A, the question and answer session. We post those as separate files, so that way, a lot of times the best gems can be found in those Q&A. So we post those as separate recordings on the CliniSync YouTube channel as well. The slides will be sent out within a week or so. We've been continually tweaking them and improving the slides. We pretty much got them in a final state, so you guys will see these slides in your inbox here in a couple days. And we are developing several tip sheets. We're probably going to be doing a yearly based tip sheets because there are some subtle and not so subtle changes each year. Today we're only going to be talking about the Stage 3 Meaningful Use Rules, and we're not going to be covering the 2015 to 2017 Meaningful Use Rules. We've already done that webinar series. The link is available here on this slide to a recording of the 2015-2017. If you can't access this link, just look for CliniSync on YouTube. You'll be able to find it there. We're also not going to be discussing the 2015 certification criteria rule. However, I do recommend you read this rule because it lists the new coding standards associated with the measures and will give you a good idea of the build and implementation and training that's going to be required as you move towards Stage 3. With that, I'm going to turn it over to my partner in crime, Miss Cathy Costello.
Hi, all. I'm sure you feel the same way we do, just about like this. But we're working our way through between 2015 and Stage 3. I think we'll get through the month. So let's start by looking at the history of when this rule was released. It's been about 3 weeks now, and actually 2 rules were released at the same time. One was the certification criteria rule for the 2015 edition, which are the new standards. And the second one was the policy, the accompanying policy rule that included both 2015 to 2017 and the Stage 3 requirements. The meaningful use measures 2015 through 2016 or 2017 and Stage 3 are effective in 60 days. The rule was published October 16th in the Federal Register, so it will become effective December 15th. There are no more changes being made to either the 2015 or the Stage 3. I'll talk about where they're asking for comments in a second. The certification rule has a different adoption period. It is going to be effective 90 days after publication, so that puts it into January, mid-January, when the certification rule becomes effective. The only 3 areas where CMS was asking for comments, we were puzzled by, we couldn't even find for a long time what they were asking for, but they're continuing to consider timing for 2018 and beyond for new attesters, how that should be handled, measures that needed to be topped out as they reached close to 100% around the country. And then I think there's going to be further guidance on the Medicaid flexibility for these rules. But as far as the Stage 3 requirements per se, the measures are set now with these rules. Okay, to review where we are from now until Stage 3 kicks in, 2015, as you know, is what you're all working on. 2016 are the same measures as 2015, what we're calling and what CMS calls a blended Stage 1 and Stage 2. The difference in 2016 is that there will be 1-year reporting, not 90 days as there was in 2015, 1-year reporting, and the exclusions will be a little bit different in 2016. So you will have to keep an eye on that next year. The 2017 is the transition year, and you can do either this blended Stage 1, Stage 2 you're working on now, or you can move to Stage 3. It depends on your institution or your practice and your vendor. A lot of the vendors are already working on the 2015 standards. Many of them have already started implementing them. Because those rules, or not the rules, but the certification criteria were actually released last year as voluntary certification criteria, so everybody had a pretty good idea of what they were going to have to build for. So it is possible, unlike stage 2, where the vendors had really less than 12 months to get everything up and running, that your vendor may be ready by 2017. So if you decide to do stage 3 in 2017, you will only have a 90-day reporting period. If you decide to stay with the blended stage 1 and stage 2 rules in 2017, then you will be attesting for a full year as you do in 2016. In 2018, everyone is on stage 3, and the reporting period will be 365 days, whether or not you did stage 3 in 2017. Okay, the approach between now and the true stage 3 adoption is that EPs will attest to 9 measures and 2 public health. Hospitals will do 8 measures and 3 public health. And as we said, in 2016, it will be 1-year reporting. Hospitals, please note, unlike the physicians and the CH hospitals, you all will have one difference next year. You will be required to report 4 CQMs electronically through the QualityNet portal. Okay. Now, in 2017, if you're reporting for the blended stage 1 and stage 2, as we said, you will be at a year. The EPs and the CAHs will be reporting exactly as they did in 2016. 9 measures for the EPs, 16 for the CAHs. The hospitals in 2017, if you are not doing stage 3, you will be back to 365-day reporting. It can be done either through attestation or electronically. Okay, if you decide to attest to stage 3 in 2017, then you move into, again, the measures contract once more, and you're doing 7 measures if you are either EP or EH. And the EPs will do 2 public health or registry reporting measures. The hospitals will do 4 public health or registry measures. In 2017, as we said, the reporting is 90 days, but please note the attestation will not occur until January because you are required to have 365 days of CQM reporting, whether or not you're doing a 90 days of meaningful use in 2017. Okay, and with that, let's look, and we're gonna have Scott jump in here to show you how the list contracts between 2015 and stage 3. As you can see, they move together again.
Yeah, thinking back to stage 2, physicians had to meet a total of 20 measures. Hospitals had to meet 19. And with the 2015-2017 rule, this was restructured into 10 objectives, some of those objectives having multiple measures. And then in stage 3, we see a further retraction where the number of objectives is again shrunk, this time to 8. And again, some of the objectives have multiple measures. Now, these next 2 slides are intended to summarize the differences with stage 3 reporting between the year 2017 and 2018. We're not going to go into any detail right now because we've got some discussion later in the slides for each of these objectives. And we just wanted to include them so that you guys will have these as reference when you receive those slides. Now, if you do decide to report to stage 3 in 2017, you can use a mix of 2014 and 2015 technology. For example, with the with objective 2, which is ERX, there is the inclusion of electronic prescribing of controlled substances. If you have a 2014 certified system that can support EPCS, then you can report to stage 3. There's a few measures where you're going to need a 2015 certified module. to meet the measure. So just kind of keep that in mind as you plan forward. Again, we're not going to go into a lot of detail now. We'll dig down here once we get to the specific objective.
Yeah, but use this as a guide to talk to your vendors, because you will have to find out how the vendor is handling these newer measures.
So the first objective is protect patient health information. You saw this back in the 2015-2017 rule, with it being the first rule as well. And there's really no notable changes from stage 2. Notice that encryption is specifically mentioned. Some EHRs still do not support database level encryption, and if your database is not encrypted, you must have a documented mitigation plan for this. You know, the goal is full encryption of data in transit at rest. It's just still not a reality for some of the EHR vendors out there. Keep in mind that the scope of this review only applies to the system and data that is created and maintained as part of your meaningful use environment. So it includes your portal, your primary EHR, if you're using a different reporting tool, just those that are part of your meaningful use program. So it's a subset of what you're required to do for HIPAA. Now remember that your security review is not a point in time. It spans the entire year, including a look back to the previous review and a look forward to any potential future changes. The Stage 3 rule also directly addresses the timing of the security review for a 90-day reporting period. The rule states that the review must occur any time from the start of the calendar year, but be complete by the date of attestation or the end of the calendar year, whichever occurs first. Like we saw in the 2015-2017 rule, the SRA tool is specifically called out. Previously the SRA tool was really thought of for use by small practices, but it's now mentioned as a possible solution for hospitals and large practices, though I do recommend engaging an external resource if at all possible to perform the security review. You can do it in-house, but it may be best served by an outside organization. Now the ONC did recently update the SRA tool and continues to recommend it because it's intended to make you consider not only the technical, but the administrative and physical safeguards that also should be in place. We're going to move to Objective 2, which is ERX. We're first going to look at the physician ERX measure, which states that more than 60% of all your permissible prescriptions are queried for a drug formulary and transmitted electronically. And of course, there's the old exclusion for a provider writing less than 100 prescriptions. Now, this threshold is down from 80% as it was in the proposed Stage 3 rule. And note the term permissible prescriptions. We're going to talk more about this in a couple slides. Now, there was a lot of discussion around the queried for a drug formulary portion of this measure. Now, the rule specifically states that the query should be either an automated or a semi-automated simple workflow contained within the EHR and should not require extensive steps or tasks outside of the EHR. So if the drug formulary is queried and returns nothing, or there is no drug formulary but you run through the workflow, then you've met the measure for that patient, and that patient should appear in your numerator.
Yeah, and this is an important point because CMS really spoke about that at some length in the rule to make it clear that what things that we were seeing as workflow at some sites where people would, come in early and query for all their patients they were supposed to see that day and, do a lot of manual type of checking and stuff is not required under this rule. CMS stated they knew that the technology was not perfect at this point in time, but they wanted to establish it as a workflow, and they would assume that the vendors would catch up with the electronic query.
Yeah, so the key is to keep the query, the work around the query within the workflow integrated in the EHR. No further work is required outside of the EHR. Now we're going to take a real quick look at the hospital side of ERX, which states that greater than 25% of all patients discharged, greater than 25% of all hospital discharge medication orders for permissible prescriptions, for new and changed prescriptions are queried for a drug formulary and transmitted electronically. Please note from the proposed rule, refills have been removed, and the same rule applies for the queried for a drug formulary. And again, there is an exclusion if you have no pharmacy within 10 miles that accepts the RX.
So let's talk about the nuances of the e-prescribing rule. The term controlled substance, which had been an exclusion under stage 2, has now been changed to permissible prescriptions. So you set your denominator by all, quote, permissible prescriptions. What is not clear is originally CMS had excluded controlled substances from the denominator and then discussed in the preliminary proposed rule that it was an optional matter. Well, they really changed the language here, and we did put in 2 paragraphs here, which you're free to look at when you see it, that really changes the tone of the discussion, because we have underlined here, we're modifying this policy that the inclusion of controlled substances should be required where it is feasible to electronically prescribe the drug and where allowable.
So the first portion of this text really makes it appear that EPCS is required. Here's where things get squirrely.
Okay, here's the next paragraph. Therefore, we are changing this measure for the objective to remove the language regarding controlled substances and instead adopting permissible prescriptions. For stage 3 objective, providers may include electronic prescriptions of controlled substance in the measure. We're not kidding. That is exactly how it is written in the rule. Obviously, escaped the editor's eye. But the question then becomes for you all trying to implement, especially in 2017, do you or do you not have to have controlled substances e-prescribing? Well, Scott and I took it to the next level and looked at the certification standards to see if, in fact, the vendors needed to be certified for EPCS. And the short answer is no. And the reason that it becomes an issue is that certification for controlled substances actually occurs through the DEA system of certification rather than through ONC system of certification. So if it's not appearing in the ONC certification standards, what they're saying is the vendors are not required to go through the DEA certification in order for you all to meet stage 3. However, it is very clear from the language that CMS is strongly in favor of this, and we honestly believe that over the next couple of years, this will pop up in one of the other rules. So we're encouraging you to look at this, and we will run a webinar about how you do controlled substances e-prescribing. But just be aware that there are 3 parts to it. Your system needs to be certified by the DEA standards. The pharmacy system needs to be certified for the DEA standards, and then the physician needs to be identity proofed. Or the prescriber needs to be identity proofed, and there must be a form of dual authentication that is acceptable for that.
And what we're recommending to folks is that you check with your authentication vendor. You know, we see a lot of Imprivata and BioKey in the state, but check with them, ensure that that piece of software meets the EPCS criteria, and then that your hardware, whether it's a biometric or a fob or a card reader, a prox reader, make sure that that also meets the DEA specifications. Now, when we do send out these slides, we are going to include some information on EPCS, but as Cathy said, we are going to do a series of webinars around that topic as well.
Right, and for the question of where it is feasible, we just included the map of Ohio to show you the pharmacies that are already certified to receive controlled substances. It is over 83% of the pharmacies in the state of Ohio can receive controlled substances e-prescribing. And of the vendors, there's over 40 vendors now that are certified to send it. So it's really up to you to pursue it at the practice or hospital level.
So now we're going to talk about the clinical decision support objective. There are 2 measures within this objective, and we don't see a lot of changes from stage 2. The measure 1 is you implement 5 CDS interventions related to 4 or more CQMs. And if you don't have 4 CQMs, then you want to map those to a high priority health condition. Measure 2 is that you've enabled your drug and drug allergy functionality. And there is an exclusion for a physician who writes less than 100 medication orders. They are only exempt from measure 2. Now, again, you must meet both objectives or be, excluded from measure 2 and meet measure 1 to meet this objective. There are no real changes from what we saw with CDS in stage 2 combined with the CDS guidance released shortly after stage 2 that expanded the definition of a CDS from what was thought of as the intrusive pop-up to also include problem-based order sets, documentation templates, clinical guidelines, and nearly any functionality that can be shown to improve patient care. Now, there is language within the rule that states that the CDS can be presented to any member of the care team and can even present outside of the patient encounter. Now we're going to move to Objective 4, which is CPOE. There are 3 measures within this objective. The first measure is more than 60% of your med orders. This is down from 80% in the proposed rule. Measure 2 is more than 60% of your lab orders are entered via CPOE. And measure 3 is more than 60% of your diagnostic imaging orders, which is a more broad term than radiology orders in stage 2. We're going to talk a little bit more about that later. There is an exclusion only for EPs. An EP who writes less than 100 med orders or less than 100 lab or 100 diagnostic imaging orders are excluded from that specific measure. To meet this objective, you have to meet all 3 measures or meet and be excluded from a total of all 3 measures. Now, one thing we did see in the text of the rule is a lot of discussion around who can enter an order and have it count towards CPOE. And of course, ideally, the physician should be the one entering all the orders, but this just really isn't a reality. The key takeaway, the key point is that the individual entering for CPOE must have the appropriate training and credentialing to respond to the pop-ups, contradictions, and CDS alerts. And those entering CPOE are at the discretion of the physician or the organization. For example, you could say that a rad tech is deemed appropriate to enter the imaging study orders. But we do recommend that you document who can enter the orders and ensure that your system's configured to meet your organization's workflow needs and that those involved have the appropriate training and credentialing and that the staff and workflows comply with appropriate laws, professional guidelines, your organization's bylaws, Joint Commission, and AAAHC.
Okay, and this again is a place where we saw a lot of discussion by CMS because there had been a lot of confusion at stage 2 about who could enter. One of the questions was whether medical assistants had to be certified at the national level to be able to enter CPOE. And CMS clarified something that they had stated by rule kind of by the FAQs obliquely, but they came right out and said in this rule that the certification does not have to be national certification. It can be appropriate degree from a health training and education program for which the medical staff has matriculated. And please note too on this slide, there are 4 points. This again is, they fleshed out an area that had been left open, is how you determine who is eligible to do CPOE, and they actually list 4 criteria. Look at organizational workflow, appropriate credentialing, analysis of duties, and compliance with federal law. And then as Scott said, write down what your policy is and then keep it with your audit information.
Now, the radiology orders from stage 2 has been expanded to the term diagnostic imaging, and this includes your ultrasounds, your CT scans, MRIs, and all other imaging studies that are generally considered diagnostic imaging. So it's a very, very broad term. Now we're going to move forward to the patient electronic access. Think of this as the first of your patient portal measures. There are two measures within this objective. You got to meet them both. The first one is kind of like what we see in stage 2 in that greater than 80% of your unique patients seen or discharged are provided with timely access to view, download, and transmit their information. The change here is that they are now also including the access via an API to that same data set. We're going to talk a little bit more about APIs here in a couple slides. Measure 2 is your patient education. There's some subtle changes here in the patient education other than the increased threshold. The measure says that greater than 35% of your unique patients seen or discharged are provided with clinically relevant information identified by your EHR and are provided access to those materials electronically. So you're pushing them to the portal, you're providing them through the APIs. In some manner, you're providing them electronically rather than printing them. There are a couple exclusions. The EP that doesn't have office visits, and then if the EP or the hospital is located in an area of low broadband, doesn't really apply to Ohio. Now let's talk a little bit about timely access, because in the final rule, if you actually read the final rule section, there is really no
measure.
Or I'm sorry, the measure. I'm sorry.
It doesn't have the time listed.
Yeah, it doesn't really have the definition of timely access. But if you read the comment and response section, it states that the proposed 24 hours of availability has been expanded a little bit. It's 48 hours for physicians and 36 hours of availability for hospitals. So it's no longer tied really to the discharge. So think about like your micro orders or other tests that come back after the patient's been discharged. If you get a micro result back, the patient's been gone for 2 days, you have to release that result within 36 hours of it being available, along with all the other information.
Right. So we included the language here that supplements the measure so that you can see that hospitals, you are still at 36 hours, but you need to post everything within 36 hours of availability. And physicians, you're moved down from 4 days to 48 hours.
Now let's dig a little deeper into the API, or the application programming interface. An API is just really a set of protocols or programming code that will allow a third-party developer to write a cell phone app, a web-based program, or some other application through which a patient can access their information. Pretty much the same as your portal, but they're just getting at the information in a little different means. So if the API can provide view, download, and transmit functionality, then technically you wouldn't need your portal, but keep your portal.
Yeah, because you're going to see APIs come up in the next measure too. There's 2 separate measures that are affected by the API.
And potentially a third.
Yeah, and right, but they specifically call them out in these 2
sure.
Because the access, this is like your functionality issues that you've had in the past. You don't have to show that you use it, you have to make it available. And this is one of those ones you need to talk to your vendor about, because there's going to be like national contracts around APIs, because the API to be most effective is going to be one that goes across a number of systems or a number of locations, so that when the information draws to the patient, it includes information from no matter where the patient was seen. So this is one that goes back to your vendor for answering some of the questions.
So do not be intimidated by the API. Think of it as an opportunity to have real-time and meaningful engagement, and as another means to increase your numerator for your view, download, and transmit measure. Now, I included this graphic to try to show the responsibility of the provider or the organization, and then where do we draw the line between what the provider is responsible for and what this API developer is responsible for. So think about your responsibility for the API like a wall socket. All you need to do is make sure that the power is flowing, and in this case the electric is the data, and that a standard plug can be used. You don't need to worry about if someone's plugging in a clock, a TV, a lamp, or whatever. You just have to make the data available. That application provider is going to do something with it, present it in a unique fashion, integrate it into like a Fitbit app, but it's really their responsibility. Think of API again in line with your portal, in that with the portal, all you really had to do was push the information to the portal, and then make the information on how to access that portal available to your patient. That's really all you're going to be doing with the API. So you're going to have a list of known compatible applications, and this list is probably going to be provided by your vendor, and then some additional basic information similar to what you'd see if you're setting up email on your or a similar app on your iPhone or your Android phone. You're going to need to know a server, some login or identifying information, and then another piece or 2 of information. Just do not be intimidated by the API.
Yeah. So to recap, for your electronic access part of this measure. You've got access and then you've got the patient ad. For electronic access, you have to have the capability to do view, download, and transmit, whether that is in your patient portal or in the API. And then you also need to have the functionality to support an API. EPs within 48 hours, this information needs to be available. Hospitals within 36 hours of availability after discharge.
So what your vendor is going to do is they're going to, behind the scenes, they're going to total up your numerator, denominator for the patient portal and the API, combine those to your thresholds.
Yeah.
All right. Next objective we're going to look at is objective 6, which is coordination of care through patient engagement. Now we're going to dig down into this one a little bit more because this is the first measure where you see a variance between what's required in 2017 and what's required in 2018. We're going to go into more detail of each of these measures, so we're just going to real quick talk about them now.
Yeah, but this is the second measure that has the API in it. So this is the one where you end up combining measures, or your totals, and we'll show you that in a minute. But I just wanted to point out, when you're considering your discussions with your vendors, this is one of the two places where you want to understand how APIs come in.
So Measure 1 in 2018 states that for greater than 10% of your unique patients, they must view, download, or transmit data via the portal or the API. In 2017, this threshold's a little lower. It's 5%, so you can kind of work up to it. Measure 2 states that in 2018, greater than 25% of your unique patients were sent a secure message. This is the secure messaging measure that it's a modified version of the secure messaging measure that folks struggled with. Again, we're going to talk about this more in a second. In 2017, this threshold is down at 5%. With Measure 3, which we're also going to dig into more shortly, states that for more than 5% of your unique patients, that either patient-generated data or non-clinical data will be incorporated into the patient's medical record. And again, there's the standard exclusion that we've seen numerous times. Now, with this objective, it's also the first that you see that you have to meet 2 of the measures, but when you go through the attestation process, you're going to enter the numerator and denominator for all 3 measures.
Yeah, so hospitals are probably going to have a different view of this particular measure than the practices, because there may be things that don't fall into the hospital workflow the same way, but you only have to meet 2 out of 3 of these measures.
Okay, so now let's dig into Measure 1, which is to view, download, and transmit or access via an API. You really technically aren't required to use the API for the portal access measure, though it must be fully enabled for this to meet this objective, and you've got to be pushing information to it. The same is still required of your portal. My advice is to begin leveraging the API, because it is going to make meeting this measure, the view, download, and transmit, much easier, because everybody has an iPhone, and if there's an app that does a view, download, and transmit, well, you shouldn't have a problem exceeding the 5% or the 25%. And again, don't forget that in 2017, the threshold's 5. It kicks up to 10% in 2018. Now, for Measure 2, secure messaging, one of the biggest issues with the Stage 2 secure messaging measure is that it was completely reliant on the patient. You had to somehow get the patient to log onto the portal, send the physician a message, and we saw organizations use contests or a portal blast message or some means to get the patient just to send a message. With Stage 3, this really flips. This measure really flips because it's driven by the physician or the hospital sending a clinically relevant message to the patient or responding to a message that was first sent by the patient. Now, messages sent from one physician to another will also count if you copy the patient. And we're back, the term clinically relevant is put back in the message. With secure messaging in Stage 2, it could be anything, but now it needs to be clinically relevant. It cannot be an appointment reminder. It can't be a billing question. So think in terms of even simple messages like, hey, just checking to see how you're feeling after your last appointment, or for hospitals, hey, did you follow up with your primary care provider?
So this is going to be a new workflow for you all, because it's not initiated by the patient. It has to be initiated by the practice or the hospital. So think about places where you would want to contact the patient and either ask a question or follow up on something. And then the second thing is you want to make sure that you again talk to the vendor, because the secure messaging capability is already built into your EHR for stage 2, but whether or not it's capturing that return message and capturing that for this measure is what you want to know.
And again, keep in mind this is one of those measures that is 5% in 2017 and then increases to 25% in 2018. Let's look at the last measure in this objective, which is the patient-generated data and data from a non-clinical setting. First, we're going to talk about the non-clinical setting, and right off the bat, that's a misnomer. It's not really a non-clinical setting. It's a non-meaningful use setting. It could be non-clinical, but it's probably not.
So, yeah, when you say non-clinical, the person who's sending is not an EP or an EH, but there are tons of other people in the healthcare area that fall into this category.
And that can include but not be limited to physical therapists, occupational therapists, nutritionists, long-term care settings or SNFs, behavioral health, home health, and even some of the outpatient departments within the hospital. Now, the biggest concern in the comments that we saw was that the data would clutter or just bloat the official medical record. So within the rule, CMS states that this data does not necessarily need to be incorporated as structured data, but it can be an attached document, a link to more information, or a sub-record within the EHR. It doesn't need to necessarily be a component of the primary medical record. It just needs to somehow be accessible. Right. Now we're going to look at the patient-generated side of the data. The patient-generated data can include information collected at the direction of the provider, like a patient with heart failure that's monitoring their weight, or even data from a Fitbit. It can be data from a medical device like a blood pressure cuff or a heart monitor. This can also include data items like family health history, advanced directives, or demographics that the patient provides either before or after an encounter. But note that it cannot include any information collected during the encounter. All that information is not patient-generated if it's within the encounter. It's just your normal captured meaningful use data.
So you could actually have the patient, you could send them a family health history, and they send it back to you via mail prior to their visit, and you key that information into your system. That would count. If you took that same family health history during their visit, it would not count.
And there is some functionality in some of the portals out there where you can put up a form that the patient would fill out and pull that information into the medical record. That's patient-generated data outside of the encounter. Our opinion is that would count.
Yeah, so ask the vendor how they're capturing this measure. If every time you put an attachment on the patient record, if that counts, or if you enter discrete data separate from a patient encounter. So there's just a question of how that's measured, but it certainly is a pretty broad standard.
Now with this slide, we're really trying to provide a visual representation of the sources and types of data included in this measure. We pretty much covered it all, so we're just going to move forward. Now for this next objective, which is the health information exchange, I'm going to introduce the concept, and then I'm going to turn it back over to Cathy for a more in-depth discussion for each of the measures in this objective. Now, when we talk health information exchange, think of that term as a verb instead of a noun, because the focus is the movement of patient clinical data between settings and providers, not
CliniSync in the sense of,
right,
of an HIE. What you're talking about here is your action with your patient's record.
So first, we want to talk about the data that is going to be moved between settings. Now, in stage 2, the data exchange in the CCDA was referred to as the Common Meaningful Use Data Set. This term's been modified to the Common Clinical Data Set because it can now contain data items outside of those that were really part of one of the old meaningful use measures. The required elements that must appear in the CCDA and be components of the CCDS are demographics, problems list, med list, methodology list. All the other fields can be left blank if no data is available, and still meet this summary of care requirements. Now, there are some new data items like the UDI number for the implantable devices. There are some more specific demographic information that is now included, like the sexual orientation or gender identity. With this, providers will also now have the ability to limit information in the CCDA to what's really they deem as clinically relevant. So a good example is if you are sending a CCDA for a patient that was, an inpatient, you don't have to send those hourly blood gases that really have no clinical relevance when the patient walks out the door. You can leave those out and only send the results and the information that will be clinically relevant to the next provider of care. With that, I'll turn it back to Cathy.
Let's look at it as a visual as to what all is incorporated in this measure, because there really are three separate measures, one in which you're looking at your ability to send a transition of care document out of your EHR to the next treating provider. The second part of the measure is, can you take in information from another source about the patient and put it in their record? And then the third part is, can you reconcile your record with the information coming in? This, again, is a meet 2 out of 3 measure. You do not have to meet all 3, but I think when you understand how this works, it'll be easier to comprehend how you can meet it. So let's start with the one that you're most familiar with, because this is what was present at stage 2. And these are the ones where you are sending out of your system CCD, or continuity of care document, that follows the patient to their next either referral or transition of care. And in that case, what you were dealing with at stage 2 was 10% of your referrals needed to be done electronically. At stage 3, it's 50% need to be done electronically. There was a lot of discussion in the rule about whether they were going to keep in the exemption or exclusion for physicians who had less than 100 transitions of care in the reporting period, and they decided to keep that in. So if you have a reporting period with less than 100 referrals or transitions of care as a physician or an EP, you can exclude out of this, but keep in mind that 100 applies even in a year where you have a 365-day reporting period. Okay, the notes on this, things that changed. As you know, at stage 2, there was a lot of confusion about what was a true transition of care. And at that point, CMS had identified 2 criteria that they considered were important to look at when determining a transition of care. The first one was whether or not the 2 providers shared a tax ID, and the second one is, did they have common access to the same EHR system? And if they were part of the same tax ID and or shared the common EHR, then it was not considered a transition of care for the purpose of that measure. CMS has really turned this around now and said, due to a lot of comments they received, that they felt it was more precise to allow a transition of care to occur, and they specifically mention whether it be, in, for example, in a group practice, or when it's part of one hospital sending to another hospital in the same system. So their new criteria about what creates a transition of care is whether or not they have separately identifiable or separately identifiable within the CMS system. So if you are an EP and you're sending to another EP with a different NPI number, then whether or not they're your partner is irrelevant. As long as you have separate NPI, that is okay. And the exception here would be physicians sending to themselves at a different location or sending to an employee. In the hospital area, same analysis if you have a different CCN, which is the Medicare ID number. If you have a separate CCN, that transition of care will count. And in the hospital setting, they specifically exclude transitions between one department and another of the same institution.
And they did include language that really defines the transition for a hospital as every patient who's discharged or transferred to another facility. So the key is if the patient walks out or wheels out, you treat that as a transition of care and send the CCDA. And really the intent behind that is to reduce the readmission rates.
Okay, so the first part was the one you're familiar with. The second part is the new one. Can you incorporate a summary of care into your patient record? And the measure here is for 40% of the transitions and referrals, can you either incorporate or can you provide a summary of care and that it's retrieved within your system, and then what do you do with it once it's retrieved? So what you want here is you're looking at those instances where a new patient comes in to visit you and you are looking to see if a CCD has been sent to you on that patient. So there's two places that you're going to be looking. One is, did you receive a direct email from a previously treating physician or hospital? And if you did not, or I mean, even if you did, you can still, the other part of this is you need to query the HIE to check for their record. So it's an either or, but you need to do both. If in fact you didn't receive a direct email, you want to be looking at the HIE to determine if their record is part of the community health record. If it is and you draw it down and use any part of that in your record, then you meet this measure. If you find that there is no record, you were not sent a direct email, and there's nothing in the HIE about the patient, then you still meet that measure having looked for the record.
Yeah, one thing to note is there is the exclusion here on this measure. For those that are kind of thinking forward to the provider set, it's more than likely going to be a different provider set that bypasses or is excluded from this measure, as you would see it in the old transition of care measure. So just keep that in mind. And this exclusion does count for hospitals, though it's very unlikely that they would be under 100 transitions of care.
Okay. So the third part of this measure is what used to be considered MedRec, and it's been expanded beyond just MedRec. So it's called actually clinical information reconciliation rather than medication reconciliation, because they want to incorporate a little bit broader understanding of what you're doing here. The first part of this measure is MedRec, the second part is med allergies, and the third is checking the current problem list. So this is for information that, again, in a new patient situation, in 80% of the transitions or referrals, you'd be checking, either doing a MedRec, checking med allergies and the problem list to make sure that that's all reconciled. And, as you know, best practices is that you would be doing this anyway. Most places are doing this as part of any new encounter. I know most hospitals certainly are doing this on everyone who comes into either the ED or inpatient. Physician offices, you want to make sure that you too are expanding your MedRec to include your problem list. And again, there is the exclusion for either EPs or EHs that have less than 100 transitions of care during the reporting period. Okay, and with that, let me see. Oh, I think Scott had already mentioned this, but let me mention it again, that under stage 3, this CCD can be split into units, rather than having to send everything that comes in under the roof. You can send the most meaningful or clinically relevant information, as long as the rest is available if either the patient or another treating provider asks for it. Okay, public health registry reporting and clinical data registry reporting. One of the biggest areas of confusion, and as you know, we've said that we are going to host the Ohio Department of Health and Medicaid in a webinar as soon as they're ready to talk about actually a lot about this, and then also the Medicaid reporting. But we'll go through the general parameters and then wait for Brian Fowler of the Department of Health to be ready to answer the more specific. Just to refresh your memory, and I think people had a fairly good understanding of this in Ohio because we're fortunate to have the Department of Health far along in public health reporting. But your public health measure can be met in one of three ways. You can register with the Department of Health for the measures that you're going to report. You can be in testing with them, or you can actually be sending them data. Any one of those three areas are going to have you meeting that public health reporting measure. What you want to make sure is that if you're just getting into public health reporting and you haven't registered yet as part of stage 2, that you get that registration done, especially if you're planning on using it for 2015. Registration needs to occur within 60 days of the start of a reporting period. One of the criticisms about the whole clinical data reporting area was that institutions, practices were concerned that they were not going to have enough notice about who these clinical data registries were, because in this measure you have both public health reporting and private data registry reporting incorporated under the same umbrella of this measure. And so the criticism in the proposed rule was nobody knows who the heck's out there that you're supposed to be considering reporting to. So what CMS responded is they're creating a centralized repository for these clinical data registries. If in fact a clinical data registry has not stepped forward 6 months before the start of the reporting period to say that they would be ready at the beginning of the reporting period to accept data, then they are excluded from being a clinical data registry for that reporting period. So you will get 6 months notice about who are the possible targets of having your data submitted to. So keep that. As soon as we see something on the repository front, we will let you know. Let's look at the measures themselves. Several of them you're already familiar with. Immunization, syndromic, electronic lab reporting are all ones that the hospitals are doing in Ohio. On the physician side, you've been looking at immunization, syndromic, and under the public health registry reporting, the only one in Ohio was the cancer registry. Let's look at how these kind of shake out going into stage 3. As I mentioned earlier, the EPs must do 2 measures reporting or take exclusions on all remaining ones, and hospitals must do 4. The exclusions, which are as important as the measure here, since you have to show that you could not meet any before you could take an exclusion. Under immunization, it's the same one that was established kind of by practice by the public health agencies in stage 2. And that is if you do not administer immunizations, you're excluded, both EPs and EHs. Syndromic's a little more interesting because these were specific exclusions created for syndromic. If you are a hospital and you do not have an ED or you do not have an urgent care, then you are excluded. This is one that we manually had to get exclusions from the Department of Health for stage 2 because the one was not in the rule. Now it is in the rule. For physicians, many of you are planning to use syndromic surveillance as your second public health measure for 2015 and 2016. Let me point out going into stage 3 that syndromic is not going to be available as a measure for EPs unless they happen to work in an urgent care setting. So basically the public health agencies are making very clear that syndromic surveillance is really a hospital ED measure or an urgent care measure and not really so much for physician offices. Case reporting is an area that needs to be flushed out. I'm sure we'll get more guidance on it, but in the regs, there were no standards for the case reporting. Public health registry reporting, as I said, was the cancer registry in Ohio, and the addition here under the stage 3 is it includes CDC reporting also. And we are starting to get more information on that and links to where the reporting is for that. But just be aware that whatever goes on in Ohio, there will also be a possibility of submitting to CDC on this one. Clinical data registry exclusion is if you don't diagnose a condition associated with that registry. So say it's an ortho registry and you're not an orthopod, then you don't obviously have to show that you're excluded from that. And ELR, electronic lab reporting, is only available for the hospitals, and only if they do the labs that are required to be reported to ODH. So to talk about registration of intent, I did mention that you have to have it on this by the 60th day of your reporting period. So you just go to the ODH site, go in and register. It's by site and not by individual practitioner. And the other thing to mention is that ODH has made very clear that you do not have to re-register at the start of every reporting period. One registration is enough.
And that ODH portal can be a little confusing. If you're not sure if you're registered appropriately or you just need some help, reach out to Cathy or I. We can definitely help you out with that.
Okay. Here are the standards for the public health reporting. I'm sure some of you, especially if you work in hospitals, will want to know this. But as I said, Brian and ODH will give us a lot more information on this sometime within the next month, I would expect. Just one last note on clinical quality reporting, just to remind you all. The reporting in 2015 is 90 days. 2016 is 1 year. Can either attest or submit for EPs. 2017 can be 90 days for meaningful use reporting, but must be a full year, whether you're doing blended stage 1, stage 2, or you're doing stage 3. That's still 365 days reporting. 2018, everybody is submitting electronic CQMs. Hospitals it's a little bit different. 2016 is your oddball year. This is for non-CAH hospitals. In 2016, you will be reporting 4 electronic measures out of either quarter 3 or quarter 4 of 2016. So that's calendar quarters. You report 4 measures electronically. You use 2014 certified measures. And there is a form if you cannot do this for extraordinary circumstances. And this particular 4 measures will also meet your meaningful use requirements.
And it's worth noting that those 4 measures are submitted through the Quality Net portal and not the attestation portal.
Right. That is a good point. And a second part of this is in 2017, you do have a full year no matter whether you're doing 90-day or 365-day reporting. And again, everybody is doing ECQMs in 2018. And in 2018, you are using the 2015 edition to report that. For CAHs, until 2018, you pretty much are doing exactly what you've been doing. You have 16 measures. You can either attest or report electronically. In 2018, you too must be reporting electronically. And with that, I think we're good.
Yeah, and I think one point to note, especially for the hospitals, you know, with the IQR up until now, you were allowed to have some chart abstraction. That's going away. So keep working on the continually improving your CQM measures. Work with your vendors, work it into your training with your staff. Ensure that you have the best picture of yourself within your CQMs. Now, also, we want you guys to keep in mind, we do have what we call the CliniSync Plus program. This is a fee-for-service that Cathy and I offer. We can provide assistance with your meaningful use initiatives, your PQRS initiatives. We're doing a lot of work now with chronic care management and the transitional care management codes. whether it's you need monthly support for meaningful use, you need support with an audit response or a mock audit. Audits are going to be stepping up. If you need help with if you want someone to come in and do a mock audit, we can help you with that.
Okay, and with that, we'll go to questions and answers.
All right. Again, enter your questions into the integrated question box. We're going to run through them now. Question number 1 is, as long as ECQMs are optional, our vendor charges a lot of money per NPI to extract the data into the appropriate QRDA format only. There's no data validation process. So whether they are ready in 2017's, our hands are tied. Is there any rule that prohibits vendors from charging providers for QRDA files?
Oh man, wouldn't you love it? There's a QRDA protection clause. But honestly, where this comes in, and I can tell you, no, there aren't any protections, even though you feel like you're highway robbery, is that the reason you get into this issue is because of the PQRS reporting, where they're moving to this very standardized, structured format that requires QRDA reporting, whether it's type 1 or type 3, it's still, you're going to get charged for it by your vendor.
Yeah, and also keep in mind they are modifying the certification process in that vendors are going to be, of course, certified in the sandbox, but they have to prove in the field that they can reduplicate the implementation. Also, part of that is they have to have transparency in their pricing model. It has to be clear on their website and in the marketing material what their pricing is going to be to discourage providers from doing this nickel and dime that we see time and time again.
Okay, next one is for hospitals in 2016. They submit 4 ECQMs through QualityNet portal instead of submitting through attestation, unlike in 2017 where you can submit either way. That is correct, and we feel the reason that is occurring is because, as you probably know, if you're a hospital, CMS was really trolling amongst the hospitals to try to get a group together for the pilot for ECQMs over the past year or two, and I don't think they got a real high participation rate. And so they're trying to draw enough data in to set their standards for ECQMs, and so the only way they could think to do it is to require hospitals to send in 4 of them, and so that would be a limited build on the hospital side, but give them enough data to set their thresholds and their benchmarks for the year.
All right, next question is, in our EHR, not all ERX orders are included in the denominator of the CPOE medication measure. So a provider can meet the objective of ERX but miss the objective for CPOE. I don't understand how this can be, but the vendor has tried to explain to me how the regulation is written. Can you explain it? Absolutely. This has came up in a couple different instances. Think of the CPOE as capturing the initial order. It has really nothing to do with the transmission method. It doesn't matter if that order, whether it's a lab order, is sent to the lab electronically or a printed rec. You're entering the CPOE and then printing a rec. It's how it's captured. The ERX measure only focuses on how that prescription is transmitted. It's captured through CPOE, but is it being sent? One, is it eligible to be sent electronically? If so, is it being sent electronically or is it being printed? So they are related but not identical. You can see a variance between the measures, but they are very, very closely related.
Okay, for CPOE, some offices have non-MAs as allied certified professionals to enter orders. For example, in ortho, we have licensed certified athletic trainer and radiology tech who enters orders. We have verified their creds and archive them into the provider's meaningful use book of evidence and mark them as certified in our system. I'm just wondering if CMS is considering offices like ortho who hire other allied professionals instead of MAs.
Yeah, those are specifically called out kind of in the rule. Yeah. That it's anybody who has the training around that specific measure.
Yeah, and they have to be trained. The thing to keep in mind here is to go back to the original CPOE regs, and that is that what CMS is trying to get away from is a situation where you were training somebody in your office to do medication order entry. And the reason they didn't like that is because they didn't know whether the person had the skills and the training to respond if there was a drug-to-drug interaction or something. So as long as you have certified that these people have gone through a recognized program, it does not have to be an MA program. If it's something that gives them the training, as we said, like a rad tech or something, that would be considered, acceptable, but please write all that out as part of your policy.
Also keep in mind that your rad tech may not be deemed appropriate to enter a lab order or a medication order, and may only be thought of as being able to enter the diagnostic imaging orders.
Okay.
That may not apply in all cases, but kind of keep that in mind.
If you're excluded from 5 of the 6 public health reporting options, do you need to document all 5 exclusions in case of meaningful use audit? Yes.
Absolutely.
I mean, and when I say document, I don't mean you need to, go to the nth degree, but you should have a few sentences written about each one to say why you believe you're excluded, because if you do get audited, this is one of those areas that they may well ask you how you met the exclusion. Certainly if you're a Medicaid provider, they do ask about the exclusions. And
I would include a copy of the policy that will be posted on the ODH website that kind of outlines the exclusion criteria.
If you're taking an exclusion that's generally recognized, that'd be a good way to take a screenshot of that.
Cathy and I are huge believers in narratives within your book of evidence. Again, it doesn't have to be anything long. Can anyone reconcile meds, problem lists, and allergies, or are certifications or proof of formal training required?
This is the one we were talking about, is for reconciliation as opposed to order entry. They specifically do not link reconciliation to either an electronic process. It can be done manually and does not have a specific credential attached to it. Obviously, that's something when you do reconciliation that the physician or practitioner should be reviewing during the visit.
So if syndromic is not available to EPs during stage 3 reporting, then it leaves EPs with only immunization registry and cancer registry as options to report. Is that correct? Well, not really.
During stage 3. Now, you're saying within the state of Ohio, that's probably true, and 90-some% of the EPs will exclude out of the cancer registry reporting. But then you get into this question about whether you're doing the clinical data registry reporting for stage 3. Now, we're not talking about 2015, 2016, 2017 reporting. We're talking about stage 3, where the private clinical data registries come back in. And that's the one that you're going to have to look at the repository that CMS is creating to see what clinical data registries are available for reporting, and then determine whether that's within your EP scope of practice.
And keep in mind that you can report to multiple clinical data registries for a single EP or a single hospital and count that multiple times. So you've got different ways to get up to your required number.
Right, and as we showed on that one slide, and you can see it when you look at it, is that some of your measures can be met in the same category. They don't have to be 2 separate measures. It doesn't have to be immunization, clinical data registry. You can do clinical data registry and report to 2 different ones and have it meet your public health reporting.
How is an ECQM different than the way we submit CQMs with stage 2 of meaningful use?
Well, if you're doing stage 2 and it's not moving electronically, then, and most people do not send theirs electronically right now, it would be you're doing it by attestation, so you're entering your numerator and denominator. ECQMs are when you take the report as it is generated directly out of your system and you send it directly on. And there's different ways that can be reported depending on the program. If you're doing it through PQRS, it can go through a data registry. If you're doing it for meaningful use, it has to go directly to CMS, and there's a separate portal for that. So when we get closer to 2018 or 2017, if you're doing that for stage 3, we can review that with people, but just be aware that there's different transmission mechanisms. but you basically will be taking the information directly out of your EHR and not making any changes to it and sending it in electronically.
Hey, Geneva, I'm gonna contact you outside of this webinar so we can talk a little bit more about your CPOE and ERX problems and the relationship. Can experience be considered formal training?
Not if the experience is coming from your office. That's specifically what they're trying to avoid. If it's experience and it's within a hospital system or something, there is nothing to say that there's an equivalency there. So you'd have to look at it on a case-by-case basis because they seem pretty clear that they want this person to have graduated from some type of program.
Can syndromic registry be used for EPs in 2015?
Yes. If you register for it, that is all you need to do to meet meaningful use in 2015.
Yeah, you're never going to be invited to proceed with the actual integration, but by registering, you have met the active engagement requirement of meaningful use.
But the other side of that, keep in mind, everyone's so concerned about having the two measures. There's only 3 possible EP measures in 2015: immunization, syndromic, and cancer registry. As I said, 90-some% of physicians are going to exclude out of the cancer registry.
Yeah, you have to directly diagnose and treat cancer for that to even be considered as an option.
Right, and for syndromic, most physicians are not going to deal with cases that would be reportable, and so you can take an exclusion. You can end up with 2 out of 3 as excluded, as long as you write, a couple sentences about why you believe your EP or your EH is excluded. That's not saying that you can't do that. You may end up only reporting 1 in 2015 and show that you're excluded out of the other 2. But should you choose to take other than an exclusion and to register for syndromic, that is in and of itself going to have you meet the meaningful use for syndromic. So you could do immunization and syndromic that way.
And for some of the multi-specialty practices, it might just be easier just to go on the ODH website and just register rather than to have some that are excluded and some that are registered. Yeah. So we just recommend that everybody just go on and register. It just takes a few minutes. Okay. Now with that, that is all the questions. I am going to look in one more spot real quick just to see if anybody entered a message or a question into the chat box, and it does not appear anybody did. Well, thanks everybody for attending. We will be putting a recording of this webinar up on the CliniSync website.
Right. So if you have any questions, let us know. And I think we'll be doing both a controlled substances webinar. We'll probably redo the 2015 one because we're still getting a lot of questions on that. And there was one, we'll do the public health reporting Medicaid one. So there are 3 more coming out. So watch for our information on our newsletter.
And if there's another topic that you'd like Cathy and I to do a webinar on that's, related to meaningful use or one of the payment reform programs or really just anything in general, we can do that. Just, send us your suggestions. Thanks again for attending.
Thank you all. Have a good evening.
And we'll talk to you later.